Dear colleague, today I will present to you a clinical case of an intra-abdominal cyst in a female fetus, which has the ultrasound characteristics of an ovarian cyst. The patient came to our attention following this ultrasound finding made by the attending physician at 30 weeks and 6 days of gestation. Ovarian cysts are not an uncommon finding in female fetuses. In fact, they represent the most common pelvic cyst during the second half of pregnancy, with an incidence of 1 in 2,500 births. They are generally an isolated finding and are not associated with an increased risk of chromosomal abnormalities. In the vast majority of cases, they are dysfunctional cysts. The pathogenesis, in fact, is attributable to hormonal stimulation of maternal but also placental origin on the normal ovarian follicles. It is of fundamental importance in cases where a fetal ovarian cyst is encountered to make a differential diagnosis with hydrocolpos, a meconium megacyst, an abdominal lymphangioma, a fourth-degree sacrococcygeal teratoma, renal cysts, and intestinal duplication cysts. Let's now move on to the ultrasound images. The first thing to do in the case of an ultrasound finding of fetal abdominal cysts is to perform a systematic approach to identify the normal cystic structures present within the fetal abdomen, which include the bladder, gallbladder, and stomach, and to emphasize that such a cyst does not have connections with these structures. In identifying the bladder, we use color Doppler ultrasound. In fact, the latter will allow us, as we see in the images below, to identify the two umbilical arteries that physiologically flank the bladder. We proceed to assess the presence of the stomach, the presence of the gallbladder, and in these cases, it is fundamentally important to evaluate the situs. In fact, alterations in situs could mislead us. The next step is to observe the kidneys to rule out the presence of a renal cyst, hydronephrosis, or urinoma. In this case, we evaluate both renal structures, which appear normal. It is fundamentally important, in addition to observing the kidneys, to also observe the intestines. In fact, it could be a duodenal obstruction or a meconium megacyst, but as previously mentioned, in these cases, the intestinal loops would appear hyperechogenic. Only after carefully examining all the structures we previously mentioned should we specifically evaluate the cyst. In our case, it is a simple ovarian cyst. In fact, the latter presents, it manifests, it appears as an anechoic cyst with thin walls and does not have a heterogeneous appearance, which can instead be present in the case of complex cysts. In fact, the latter presents with a liquid formation of 31 millimeters with completely transonic content, without septa, without internal vegetation, without endoluminal effusion, but inside it has a small cyst, known as a daughter cyst, one of the very characteristic signs of fetal ovarian cysts. Furthermore, on color Doppler, the latter does not appear to be vascularized. All the ultrasound factors, therefore, indeed suggest that it is a congenital type ovarian cyst. It is of fundamental importance, of course, in these cases to assess that it is a female fetus, as we see in the images below, but even more important is to evaluate that it is not associated with complications that these ultrasound findings can often cause, such as polyhydramnios, which occurs in about 10% of cases of fetal ovarian cysts, seemingly due to an alteration of peristalsis. In this particular case, by evaluating the amniotic fluid with the AFI indices, it appears to be normal, and also assessing whether there are signs of ascites which in our case do not appear to be present. The fetus shows regular biometry for the gestational age, and all the flow measurements also appear to be normal. Furthermore, in cases of fetal ovarian cysts, the visualization of the profile is of fundamental importance. In fact, it has been observed that in a percentage of cases, such cysts are associated with the presence of a fetal goiter. In our cases, we see that the profile of the fetus under examination appears to be regular. It is also fundamental to carefully evaluate the pathological history of the mother, as in a percentage of cases, such cysts correlate, for example, with the presence of gestational diabetes. What to do in these cases? Nothing. A careful evaluation, a careful ultrasound follow-up, requesting a pediatric surgical consultation, and performing ultrasound checks at birth. Only in the case of ovarian torsion, obviously, will the child need to undergo surgery, but it is important to emphasize to the mother that currently there is no scientific data highlighting the need to intervene in utero to perform a percutaneous aspiration of the cyst. Therefore, wait. Thank you for your attention.